right, next up we have our resident research presentation and competition. This session allows residents to showcase their current research. It's also an excellent networking opportunity with all of you here this weekend who are interested in similar research topics. Dr. Teresa Bird, chairman of the GOGS Education Committee, will be the moderator for the poster competition today. A brief question and answer session will follow each lecture. Dr. Teresa Bird is an academic leader in obstetrics and gynecology, currently serving as the director of the OBGyn residency program at Wellstar Kennestone in Marietta, Georgia. A native of Los Angeles, she earned her degree from Meharry Medical College and completed her residency at the University of Texas at Houston. Dr. Bird has dedicated her career to medical education, quality improvement, and advancing diversity and equity in healthcare. She is actively involved in initiatives to reduce Black maternal mortality and serves on several national and state healthcare committees, including GAP-QC. Welcome to the stage, Dr. Bird.
All right, so we are going to go ahead and get started. One thing I want to make sure, all of you should keep your phones out because I believe we'll have the Slidos to do the voting after each one. And I will say that I've had the pleasure of serving on this committee and working with, through our statewide QI collaborative, working with a number of the residents from the other programs. And I just want to say that these residents do a lot. Some of them not only have the projects that they're presenting today, but have worked on the statewide protocols that we have. And many of them do that with not a lot of support from our faculty and our hospital systems and doing the grunt work themselves. So I just want to applaud them for all of their hard work and just know that it doesn't go unnoticed. And it lends itself to the wealth of evidence that we have in the field now. So, and these are excellent residents, and so I'm excited. All right, so as I said, you will have the opportunity to rate each one of the presentations immediately following each one. So we would just encourage you to stay to hear all of the presentations. That would be phenomenal. And then we will announce the winner in the GOGS newsletter that's coming up in October. The first presentation is going to be Dr. Autumn Acklin from Morehouse School of Medicine. She's going to talk to us about implementing cardiac screening for postpartum patients. Dr. Acklin.
Good morning, everyone. Thank you so much, Dr. Bird, for that introduction. My name is Autumn Acklin. I am a current PGY at the Morehouse School of Medicine, and I am so grateful to be presenting to you all my project entitled Implementing Cardiac Screening for Postpartum Patients. I have no financial disclosures or conflicts of interest. So, the Maternal Mortality Review Committee of Georgia noted the following as top 5 contributors for pregnancy-related deaths in 2020 through 2022. I think it's important to note that cardiovascular disease outweighed even COVID-19 during this period. At that time, it was noted that 37.9 pregnancy-related deaths per 100,000 live births occurred, with 65% of them happening in the postpartum state. And it was noted during this meeting that 87% of these deaths could have been prevented. So what risk factors are associated with cardiovascular disease? This can be shortness of breath, fatigue, lower extremity edema, a history of chronic hypertension or diabetes, even obesity. And I think it's important to note that sometimes we kind of write these symptoms off as signs of just normal pregnancy. And so this can contribute to patients falling through the cracks. This can lead to delayed or inadequate response to clinical signs and symptoms, ineffective or inappropriate treatment, misdiagnosis, or failure to appropriately consult other services. And so we looked to the state of California for some guidance. They had previously noticed a trend in 2008 to 2016, where they also found that cardiovascular disease was about almost 30% of their pregnancy-related deaths. And so with this information, they created a tool that they used to retrospectively look at 64 cases. And of those 64 cases, it was noted that 88% of those cases could have been identified. And so we said, let's use it. And with that, we decided to implement this cardiac assessment model in a statewide quality improvement initiative to screen for cardiovascular disease. And we specifically screened postpartum patients that were delivered by the Morehouse team at Grady Hospital. This allowed us to triage patients based on screening results into 2 categories: no further evaluation or preliminary cardiac screening. And so when looking at our methods, the screening tool itself was validated by ACOG, and it kind of broke down into different symptoms that we would look for. So specifically symptoms that were noted to be in the NYHA class greater than 2, and that could be shortness of breath, lightheadedness, palpitations, chest pain, and then also we looked at their vital signs as well as risk factors that automatically have you at increased risk for cardiovascular disease, including an age greater than 40, being or identifying as African American, having a pre-pregnancy obesity or BMI greater than 35, pre-existing diabetes, hypertension, history of substance use, and history of chemotherapy. And during our physical exam, we specifically evaluated patients for heart murmurs and bibasilar crackles. So to screen in, you had to have either one of these symptoms be positive in each of these categories, or a total of 4, regardless of the category, or you could have a red flag symptom, which was considered the heart murmur or bibasilar crackles that would rule you in. Our patients were screened on postpartum day 1 or post-op day 1 from July to December 2024. And an EKG and BMP were ordered for patients who screened positive, and no patients were excluded from the screening at this time. And so, looking at our demographics, we noted that our screening specifically showed that a majority of our population identified as Black, as well as a significant amount of them had obesity greater than 30. And just to see how this stood compared to other studies that had also used this screening tool, specifically published in 2020, Blumenthal et al., they used the screening tool throughout pregnancy as well as the postpartum period in California and New York. So we just wanted to compare and see how our numbers looked against that. And then specifically, out of the 882 deliveries that we had by our team in July through December, 113 patients were screened, and of those 113 patients, 5 patients screened positive. And 3 of those ruled in based on the moderate risk factors, while 2 did exhibit red flag symptoms. So as I noted, our population notably had a high ratio of patients who did identify as Black and had a high BMI greater than 30 compared to studies who had previously used this screening tool. Our positive screen was noted to be 4.4%, and while this might seem like a low positive screen rate, I do think it is extremely necessary that we continue to screen our patients, specifically because when we looked at in 2019 through 2021, Black patients accounted for over half of the pregnancy-related deaths here in the state of Georgia. And so this study did allow us to be proactive in evaluation of patients, especially in the immediate postpartum period. We were able to review collected data to ensure accuracy and make sure that these patients got appropriate screening if indicated. And then there was no additional cost for the hospital as far as being able to just order an EKG and BMP. Those resources were already there. I will say that, as you noted, we had 882 deliveries, but only 113 patients were screened. And so did note that there was an inconsistency in provider implementation that led to misscreenings. So we had less than 13% of our patients screened. And then there was also a need for department-wide training. When we initiated the screening, we did train the residents as well as attendings, but we're not the only people that are involved in screening or postpartum care, so including our students and our midwives. And so, what can we do in the future? The goal would be to screen throughout pregnancy, so at least once a trimester, screening patients admitted to the antepartum unit, and also screening up to 1 year postpartum, as well as including all clinicians that are involved in the care of our patients, so both OBGYN and family medicine programs. These are my resources. I would like to thank the Georgia Perinatal Quality Collaborative and Dr. Bird for offering us this amazing research opportunity, and can't wait to continue. And special thanks to Dr. Phillips and Dr. Olamrewaju for ushering me in and allowing me to get to work. Thank you all.
Questions?
What kind of study would you term this? Would you just term it as a cohort study or a retrospective case control, or what?
I would term it as a prospective cohort study. As of right now, really a quality improvement initiative, but yes, prospective cohort.
Hi, Ruth Klein, Athens, Georgia. I thought your slide was very interesting, comparing the data from California and New York in the screening, and then you did allude to the fact that over 50% of the women who delivered at Grady were African American. I think it would be interesting to look at those numbers in detail, because I think to have more general application to a population, you're looking at a more urban population, and yet I would like to emphasize that in more rural communities, it probably doesn't have as much racial deference, the higher risk of cardiac disease in the postpartum interval.
Yes, absolutely. Thank you for that.
Hey, I'm Tanner. I'm a fourth-year resident in Savannah. We did the similar project. My question was, for the 4% of patients that did screen positive, what kind of follow-up was set up for those patients?
So they did get an EKG and BNP. Unfortunately, that was the limit of follow-up. I think one of our kind of sometimes barriers to care is that our deliveries aren't always completed specifically from our clinic that we see, so we don't always have the appropriate follow-up for patients. We have a lot of outside clinicians that we collaborate with, and so we would need to make sure that we have appropriate follow-up for like our patients that we aren't seeing in the postpartum period.
Thank you. Thank you. And now you guys can pull out your phones. It was here a second ago. Let's see. We pulling up the Slido. Do I need to advance? It was on my screen a second ago. There we go. So go ahead and pull out your phones and scan the QR code in order to rate, and then we'll take a second for this. No music this time? Thanks. All right, we're going to move on to the next presentation. Oh, I advanced. Let me go back. Next, we will have Dr. Bailey Brown from Memorial Health Savannah, and they will be talking on contribution of low birth weight to neonatal intensive care unit admission among newborns delivered at HCA hospitals in the state of Georgia, a mediation analysis. Dr. Brown.
Hello, can everyone hear me? I'm Dr. Brown. I'm one of, like Dr. Bird said, the fourth-year residents at Memorial in Savannah, and this is my project on the contribution of low birth weight to neonatal intensive care unit admission among newborns delivered at HCA hospitals in the state of Georgia, a mediation analysis. I do not have any financial disclosures. So a little bit of background data that kind of led us to pursue this research project. We do know that maternal race/ethnicity is associated with adverse neonatal outcomes, such as NICU admission, and we think that there is possibly a contribution of low birth weight in this association. We also know that in the state of Georgia, our prevalence of low birth weight is higher than the national average. And lastly, we know that adverse neonatal outcomes often occur more frequently or are found to occur more frequently in the Black or African American population. So the objective of our study was to examine the risk of NICU admission of live-born infants delivered at HCA hospitals in Georgia in relation to maternal race and mediated through low birth weight. Our hypotheses, we had two. The first was the prevalence of NICU admission will be increased among infants born to non-white women. The second is that low birth weight will mediate the association between maternal race and NICU admission. The schematic on the right, I think, is a helpful illustration of what a mediation analysis is. So we know that there's an independent variable X that can affect a dependent variable Y, but there are certain factors that play into that association, and so they're called mediators, and the mediator that we looked at in this study was low birth weight. So the methods of our study, this was a retrospective cohort study. It was performed on pregnant women greater than 18 years old who were admitted to an HCA hospital in Georgia over a 4-year span. That gave us 10,387 participants. These mothers obviously delivered a live-born infant. The variables, like I explained on the slide before, our independent variable was maternal race, our dependent variable was NICU admission, and then our mediator was low birth weight, or infants born weighing less than 2,500 grams. We did analyze some other covariates in the study, and those were age, race, BMI, smoking status, anemia, and maternal substance abuse. So to the results. The table on the left is kind of showing a breakdown of the participants in our study based off of race. Of the 10,385 women in our study and babies born to these women, 6.2% were low birth weight and 6.8% were admitted to the NICU. The table on the left looks at some of those covariates I talked about and how they relate to NICU admission. So we found with our data that increasing age, white race, increasing BMI, maternal anemia, and a low birth weight infant all contribute to higher NICU admissions. This slide is kind of important because if you remember, one of the hypotheses that we hypothesized was that infants born to non-white mothers have a higher rate of NICU admission, and so we actually found that babies born to white mothers have a higher rate of NICU admission. This next slide of results, the top table looks at race and how that plays a role in low birth weight. So we found that infants born to Black mothers were 2.3 times more likely to be low birth weight than infants born to mothers of other races. And then when we compared Black race to white race directly, we found that infants born to Black mothers were 2.7 times more likely to be low birth weight than infants born to white mothers. The table on the bottom, similar to the table on the previous slide, looked at some of those covariates, but instead of looking at NICU admission, we're now looking at low birth weight. So we found that infants born to mothers who smoke or infants born to mothers who use illicit substances are more likely, 2 times more likely, to be low birth weight. Interestingly enough, we did see that BMI actually is a protective factor against low birth weight. So the big takeaway from this whole study is the sentence that you can see at the bottom of that slide that says the proportion mediated or indirect effect was 8.8% calculated through the difference method. So basically what that means is, if you remember that schematic from the beginning, we looked at maternal race and how it played a role in NICU admission through low birth weight. So now we know that 8.8% of the association between race and NICU admission can be attributed to low birth weight. So some of the discussion and kind of a summary of the presentation. We do know that infants of Black mothers are more likely to be low birth weight than infants born to white or other race mothers. And we do know that low birth weight does contribute to the association between race and NICU admission. But it's not the only determinant, and that there may be unmeasured or unidentified pathways by which other factors can operate as shared mechanisms. So I think this is a good avenue for further research, for sure. And then this is a pretty important point. So although the proportion mediated through low birth weight was relatively small, only that 8.8%, we do know that there are over 120,000 live births each year in the state of Georgia, and over half of those babies are born to non-white mothers. So that means that there could potentially be significant morbidity in this cohort, and that could put a substantial load on resource utilization and healthcare costs. So this study did confirm the existing body of data, and it filled a gap regarding the prevalence of low birth weight and NICU admissions among non-white infants delivered in HCA hospitals in Georgia. And I think that this information can be really useful in planning and allocating healthcare resources. Thank you.
So maybe I'm just old and I'm mixing things up, but low birth weight is a big bucket and has prematurity and IGR in there. So that didn't matter?
So we'd use just that 2,500 gram cutoff as, for babies to qualify for that low birth weight. We didn't further subsidize them into the different causes of low birth weight.
Do you think that would matter?
I think it definitely, I think further research doing that would be important. And I think another thing that we could potentially look at as we were going through this data is we didn't stratify gender. And I think that also, male versus female infants could be an important, distinguishing factor.
Thank you so much. And Dr. Bunk, your question was helpful because it leads to mine, which is, what made you think about mediation versus effect modification? Because if you had utilized effect modification, you could have potentially stratified based on the categories. But with mediation, you end up putting them all together. So just curious how you guys thought about that.
Yeah, so I will be honest, I am by no means a statistician, and I had great statisticians who helped me kind of analyze this data. And so, that was the way that they said that, would be a good way to do this study. But like I said, I think that this is kind of just a launching pad, and there's plenty of different avenues that we could take this research. And so I think, it's a good place to start, but definitely not comprehensive, and, we can definitely continue this research.
Thank you.
Thank you.
So once again, go ahead and pull out your phones and scan the QR code and take a few seconds to rate Dr. Brown's presentation.
4 years, no calls. Now you're looking pretty in a hotel bar, and I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Bite that tattoo on your shoulder. Pull the sheets right off the corner of the mattress that you stole from your roommate back in Boulder. We ain't ever getting older. We ain't ever getting older.
All right, we're going to move on to the next presenter. Next, we have Dr. J. Alexander Dyas from Navicent, who's going to present on inhibitors and cardiotoxicity. Dr. Dyas.
Good morning. As she mentioned, my name is Alexander Dyas. I'm one of the fourth-year residents over at Atrium Health Navicent in Macon, Georgia. And I really appreciate y'all's time this morning, allowing us to present our research. And I'll kind of jump right into things. My project was entitled PARP Inhibitors and Cardiotoxicity. And before I get kind of into it, I did want to mention my research mentor, Dr. Ilana Heffitz, who, without her help, this certainly would not have been possible. I have no disclosures to report, unfortunately. A little bit of background, PARP inhibitors are a type of targeted cancer therapy. We'll kind of get into the functioning of them here in just a second, but it's been utilized in ovarian, breast, prostate, as well as pancreatic cancers. And as we see kind of improvements in the molecular testing and as we get a little bit better at identifying these tumor genetics, there's a natural transition to a more targeted approach to cancer treatment. Our project specifically is a T0 translational study that utilizes a mouse model to evaluate an anti-cancer therapy. In our project specifically, we used olaparib as our representative PARP inhibitor, as it was the first PARP inhibitor that was approved by the FDA for maintenance monotherapy in ovarian cancer. So how do PARP inhibitors work? Well, they tend to be most effective in BRCA1 or 2 germline variants or tumors that are deficient in homologous recombination genes. The reason being, PARP is an enzyme present within the body that is functioning in single-stranded DNA repair. When you have tumor cells that are deficient in either BRCA1 or 2 or homologous recombination genes, they've naturally lost the ability to repair double-stranded DNA breaks. So as you see kind of in this image over here, the bottom side, when we combine the natural deficiency in these double-stranded DNA repair breaks, combined with PARP inhibitors, we effectively prevent the ability of these cells to propagate their DNA, and ultimately it results in cell death. Kind of jumping right into our project, the treatments we use, we took weight and age matched 10-week-old mice, and we treated them with either cisplatin, which was another representative anti-cancer treatment that has historically been used in ovarian cancer, and we gave either 1 milligram or 10 milligrams once a week for 3 weeks, or we treated them with olaparib, 50 milligrams per kilogram or 200 milligrams per kilogram once a day for 14 days. We also had a control group that was injected with just vehicle alone, and all of our treatments and controls were delivered via intraperitoneal injections. Ultimately, at sacrifice, the hearts, aortas, and retinas were harvested from these mice, as well as the serum in order to break down our analysis. So what we looked at was kind of a little bit of a variety of things. The first was a marker of vessel damage. So what we know is that cardiac fibrosis, collagen deposition, all of these play a role in cardiotoxicity. So in terms of macrovascular damage, the hearts were stained, they were sectioned, and the aortas were also stained and sectioned, and then wall thickness and collagen deposition were evaluated. In terms of the microvascular damage, we took the retinas from these mice and using a fairly well-established model to assess microvascular damage, evaluated the number of acellular capillaries that were present within these different tissues. We also did PCR analysis of 10 genes that were previously shown to be associated with cardiac fibrosis and cardiotoxicity. And finally, we took the serum from these mice and evaluated osteopontin, which is a matricellular protein that is involved in quite a variety of biological functions, but most importantly is the way that it's thought to increase and predict a poor prognosis for major adverse cardiovascular events. Our results, what we saw initially was a dose-dependent increase in cardiac fibrosis, so that macrovascular damage, in both mice that were treated with cisplatin as well as olaparib. We also saw a dose-dependent increase in collagen deposition in both olaparib and cisplatin. And I think that this image over here to the right is kind of one of the more interesting ones. This is our control group, and as you come down to the highest concentration of olaparib that we gave, you can see there's a lot of empty space, there's a lot of kind of room within that tissue, versus down here, there's virtually no additional space. Everything is very crowded, and so that was kind of our marker of collagen deposition. We also saw higher doses of cisplatin and olaparib that significantly increased the aortic wall thickness. We noticed that there was a significant increase in microvascular damage as by way of those acellular capillaries. We found that there was a significant increase in the gene expression of several profibrotic genes within the heart. And finally, we saw a dose-dependent increase in the concentration of osteopontin within the mice serum following treatment with olaparib. So in conclusion, what we were able to draw from this study was that treatment with olaparib resulted in an increase in cardiotoxicity, specifically within our mouse model. And treatment with olaparib also increased the expression of several genes that have previously been shown to be associated with cardiotoxicity. And these are my references.
Thank you, Dr. Dyas. Bungeron Ray, G1 Oncology, Medical College of Georgia. I have a question and a comment, so I'll ask my question first because it determines my comment. Were these mice, what was their germline BRCA status and what was their HRD status in your model?
So they were BRCA negative, and then they were not homologous recombination deficient.
Okay. Then in that case, my comment is that I would encourage you to replicate this study using niraparib instead, because niraparib, as you know, is FDA approved for germline negative HRD proficient, which would be your mouse model, and niraparib's primary side effect is hypertension. So I would be really interested to see what that looks like in this mouse model. If you're showing it with olaparib, which doesn't typically have hypertension associated with it, I think you'd see really profound results if you replicated it with the other drug.
Yeah, agreed.
Thank you.
Thank you.
Thank you, Dr. Dyas. All right, so you know the drill. Pull out your phones, play the music.
When it's all said and done, I'm not okay, but it's all gonna be alright. It's not okay, but we're all gonna be alright, gonna be alright, gonna be alright. I know one day we'll see the other side. The pain will wash away in a holy water tide, and we all gonna be alright. I know I can't be the only one who's holding on for.
All right, we are going to move on to the next presentation. Next up, we have Dr. Kristen Ezeude from Wellstar Kennestone. She is going to present on a doula's impact on antepartum, intrapartum, and postpartum experiences and early detection of cardiovascular conditions in underserved populations. Dr. Ezeude.
Thank you, Dr. Bird. Good morning. My name is Kristen Ezeude. I'm a fourth-year OBGYN resident at Wellstar Kennestone, and today I will be discussing my research on a doula's impact on antepartum, intrapartum, and postpartum experiences and early detection of cardiovascular conditions in underserved populations. And I want to say thank you to Dr. Bird as one of my research mentors, as well as Dr. Maya Hagans. I do not have any disclosures this morning. Just some background on doulas. Doulas are healthcare liaisons that help to provide continuous physical, emotional, and informational support for our patients before, during, and after childbirth. And there has been an increased desire for doulas, which we may have been seeing on social media. And to tie that into, there has been incorporation of doulas in maternal care because there has been some signs that there has been increase in satisfaction rates and pregnancy outcomes. As we know, this will slowly tie into the project because in Georgia, there is an increased rate of maternal mortality in the United States of America. And as we know, one of the main reasons is because of cardiovascular conditions in the postpartum period. So you may be asking, what is the significance? Well, Georgia is currently working on implementing doula pilot programs in the Medicaid system to help provide coverage for doula care for our Medicaid patients. WellStar has been blessed to receive grants where they have been able to pilot an initiative program where we are able to provide free doula care for our underserved patients before, during, and after childbirth for up to 1 year postpartum. And the sites below are the ones that are incorporated in, that are able to receive this doula care. So the WellStar sites at Kennestone, Cobb, Douglas, MCG, North Fulton, as well as Spalding and West Georgia. So there are 2 research questions that were addressed in my project. The first one is, how does the incorporation of doulas impact antepartum, intrapartum, and postpartum patient experiences, as well as do doula postpartum visits aid in timely evaluation and intervention of cardiovascular conditions? Our project is a quality improvement project that has been approved by the WellStar IRB. We do have some inclusion criteria, which are the patients have to be Medicaid eligible or expectant. They have to reside and deliver in a county that is home to a WellStar delivering hospital, and they cannot have received doula care in their previous pregnancies, and also they have to participate in doula postpartum visits, which occur 1 week after delivery, 1 month after delivery, and then monthly up to 1 year after delivery. The exclusion criteria are no prenatal care, no private insurance, and then non-compliance with blood pressure monitoring, as well as non-compliance with medical evaluation. And we analyzed surveys that were collected between August 2024 and March 2025. So there are 20 trained doulas that were paired with 256 patients. In phase 1 of our project, we looked at the patient perspectives of their doula care. So after the patients delivered, they received a survey through Microsoft Forms, rating their experience from 1 to 5. There were also some open-ended questions that they could answer. Phase 2 of the project, we utilized the doula postpartum visits that happen at the patient's home for up to 1 year. And we did this so we could educate our doulas on how to screen our patients for cardiovascular disease. And we used the CMQCC guidelines. And we did an educational session in August of 2024. And afterwards, the doulas were able, whenever they went to visit the patients, to screen the patients. So for the first phase of the project, we looked at the patients' satisfaction rates, essentially with their doulas. So we only received the 86 surveys, which is a 33.5% response rate, given that there were over 200 patients that received doula care. However, all of the patients astoundingly had a great experience with their doulas. As you can see, for the questions that rated from 1 to 5, the mean score for all of them were over 4.5. For phase 2 of our project, we were doing the cardiovascular screening. There were 266 screens that occurred, and it just so happened to be that out of those 266 screens, there were 8 that were positive screens, and it happened to be that those were 8 separate patients, which was 3% of the patients that were screened, and out of those 8 patients, 4 of those patients were readmitted for postpartum preeclampsia. So in conclusion, doulas positively impact our patients' satisfactions during their antepartum, intrapartum, and postpartum experiences. And because patients are enjoying their experiences with their doulas, we can also utilize the help of our doulas to be able to send them out when they're going at home to visit the patients, screen them for cardiovascular disease, and possibly decrease the rate of cardiac-associated morbidity and mortality here in Georgia. And we can utilize that in our next steps to help with another QI project and to see the effectiveness of screenings of postpartum depression during these home visits as well. And here are my references, and thank you for listening to my wonderful project.
Great job, very interesting.
Thank
I
you.
have two questions for you. One is, what is the validated survey you utilized to acquire the data?
So the survey was completed by the Doula Initiative program. They basically put together questions on the Microsoft forms and sent it out to the patients. So
So it's a validated survey, or it was questions, like, has it been previously validated in any population?
it's not validated.
Okay. And then my second question is, what are your thoughts about your next steps being a mixed methods model? Because you were able to do the survey part, but it looks like you also got interviews. And you have 86 patients, which is a very significant N. And so is that something you guys have thought about, is doing it in a mixed methods model versus just looking at it from the data itself?
We have not thought about that, but we would definitely discuss that and see if we can do that with the next steps. Thank you.
Hi, I'm Winnie Sufi. I'm in private practice, and I've experienced a whole variety of types of doulas. Some are can be very sort of against what we want to practice, and they want to go against medical advice. How did you choose the doulas, and was there any standardization, or was there any kind of screening of the doulas that you used in the study?
Yes, so the WellStar Health System interviewed the doulas, and they trained them prior to them being allowed to work with the patients. And that is a great comment. I personally have experienced delivering with some of these doulas in our deliveries, and they have been very supportive with our recommendations and helping to convey that to the patient. So I haven't experienced any negative experiences with our WellStar doulas.
So this is Kathy Boncticare. This is low-hanging fruit. Did the people that screened positive and then got admitted for preeclampsia, did they do the survey? You should look at those 8
Yes.
people, and because their results, like if you find something bad and somebody gets taken care of, I'll bet they did the survey. That would be helpful.
Yes, thank you. Yes, Dr. Cyril? Yeah. Yes, go ahead.
So why did your inclusion criteria include people who had not had a doula in a previous pregnancy? And was a power analysis needed for this type of study?
So we did not include patients that had a doula in previous pregnancies because we didn't want that previous experience to possibly have, extra conflict in the current experience with the WellStar doulas. And we did not do a power study on that.
Hi, Ruth Klein, Athens, Georgia. What was the uptake of doula services for patients, such as how many were offered and how many accepted? And then do you think that impacts your results based on the fact that if there was a large group of women who were offered doula services who declined doula services, to maybe have looked at what their experience was versus what your doula patients were?
That's a great comment. Unfortunately, there wasn't a way to track the patients that were offered the doula services because it was offered during their prenatal care. And then, there's a large range of practices that offer this, so we didn't keep track of that, but that's something that we could look at going forward in the project.
So go ahead and take out your phones, scan the QR code, and take a few seconds.
I'll take you far away. I'm a new soul. I came to this strange world hoping I could learn a bit about how to give and take. But since I came here, I felt the joy and the fear, finding myself making every possible mistake.
All right. We are going to move on to the next presentation. Next, we have Dr. Kristen Reinhardt from WellStar MCG. He is going to present on preeclampsia in the Peach State, evaluating the S-FLT1 and placental growth factor ratio in a high-risk population. Dr. Reinhardt.
Good morning, everyone. I'm Christian Reinhardt. I'm one of the fourth-year residents at Wellstar MCG, and today, like Dr. Bird said, I'll be talking about preeclampsia in the peach state, evaluating this biomarker test ratio of S-FLT1 to PLGF in a high-risk patient population. I'd like to thank my research mentor, Dr. Woodham. I have no disclosures yet, like someone said yesterday. So before we start, I want to take a second to preach to the choir a little bit, a room full of OBGYNs about the prevalence of preeclampsia. So about 16% of pregnant women in the United States suffer from some flavor of hypertensive disorders of pregnancy. So that's chronic hypertension, preeclampsia without severe features, gestational hypertension, and preeclampsia with severe features. As of the most recent data that we have from 2022, the global incidence for preeclampsia is about 2 to 8%. Although for some preliminary data we have, our patient population is about double that percent. From 2007 to 2019, the incidence of hypertensive disorders of pregnancy have nearly doubled in the United States, with accelerating rates since 2014. About 37% of patients who present with a hypertensive disorder of pregnancy, being preeclampsia without severe features, eventually will develop severe features. It accounts for about 1/3 of all obstetric costs in the United States. This arrow represents the beginning of this steep incline. So to briefly discuss what this test is, what this means, this here represents a healthy pregnancy where the FLT1 receptor is being agonized by VEGF, placental growth factor, other types of growth factors that stimulate endothelial proliferation and generation of blood vessels. This assists mostly with placentation. So in a preeclamptic pregnancy, a soluble FLT1 receptor, which is, by the way, FMS-like tyrosine kinase, to define our terms, will in the bloodstream bind free VEGF and placental growth factor, interfering with this vascular proliferation and normal endothelial proliferation that results in good placentation. The research shows that the levels of S-FLT1, so the soluble form of this receptor, increase as pregnancy progresses, and that the levels of placental growth factor thereby decrease as the pregnancy progresses. That's demonstrated here in this graph, which I will not bore you by explaining. The one important portion of this slide is that the deviation from normal levels from both S-FLT and placental growth factor occur very, very early on in pregnancy. So this is an exciting opportunity, when we're looking at the healthcare costs that preeclampsia presents to our healthcare system. This is something that could potentially be identified very early on as something to intervene with. So this is a study that we are comparing our personal MCG data to. This is the PRECIS study. That was published in the New England Journal of Medicine, that initially the FDA approved their test based on this data. So what I would like to highlight here is that there is it is a highly sensitive and highly specific test that they've published their data for and that the FDA approved based on this data. It also has a very, very good negative predictive value, meaning when you receive a negative test, that the patient truly does not have preeclampsia with severe features. There's also a very good positive predictive value here of about 65%. With the most important results being that, in the African American population, about 99% negative predictive value. So this is a pretty significant slide here that shows that the area under the curve here, when you compare the sensitivity and specificity of this test, it's significantly more accurate at detecting preeclampsia with severe features than all of the other things that we're used to diagnosing preeclampsia by. So you think about platelets, systolic, diastolic blood pressures, creatinine, things like that, AST and ALT. So here's our data. I put it in this format to sort of illustrate how we come up with these numbers for all of the non-statisticians, including myself in the room. So we have an excellent positive and negative predictive value with a test that's highly sensitive and specific in our patient population. We had to throw out some numbers that our providers got this test in multiples. It's not approved for multiples. They, things like that. So our final N was close to about 85 for the first year. And actually, this was the wrong version of my slides, so I'm gonna talk about a couple of things that I didn't get a chance to mention. I saw that early on that this is the wrong version. So essentially, what we did is this is a retrospective look at our first year's worth of data collection and how we. I'm going to go back a couple of slides while I talk about this. So this is a retrospective look at how our data resembled that initial data for the PRECIS study that was used for the FDA approval for this. And our sort of aim was to say, hey, is this something that in a high-risk patient population, when it's known that the statistical principle of as you increase the prevalence of something, the positive predictive value should go up, the negative predictive value should go down. And we did show that. So our positive predictive value, it's on my other slides, for the PRECIS study was about 65%. So this is a truly excellent test for our patient population. And I think that the way that ACOG talks about this test is this is something that could be a prognostic test rather than a diagnostic test. And so for our patients who come into the OBED or are hospitalized or as a transfer for severe range blood pressures, lab abnormalities, things like that, this is a great way to confirm that diagnosis. Interestingly, one of the things I wanted to discuss is that we had a high rate of false negatives here in this chart. It's 8 out of 44 tests that were performed were false negatives. And the way that we make that distinction is that we say, okay, we have a low test result. In my other slides, it says that the positive value for this, the ratio result value, is greater than 40. And so this would be a result that was less than 40, which should demonstrate a low overall risk of developing preeclampsia with severe features within 2 weeks. And we had a pretty high percentage of false negatives, which drove down our negative predictive value and drove down the sensitivity in our study. On our preliminary analysis of this data set, about 5 of those patients were diagnosed with preeclampsia with severe features based on only blood pressures. And so these were chronic hypertensives that then came in as either a transfer from another hospital or to our OB emergency department with only severe range blood pressures, no lab abnormalities, no symptoms at all. But out of a culture of patient safety that we're all familiar with, the safest thing to do is diagnose that patient with preeclampsia with severe features, say, hey, this is probably the pregnancy that's causing this, and sort of we know the treatment from there. So if you take that false negative number and turn it into a 3, our negative predictive value is about 80%, with the sensitivity being closer to about 85%. I know that's bad stats, but then this is all just preliminary data we're presenting, but it's an important point to consider with how we use this test moving forward. So sorry about the wrong slides. I appreciate y'all's patience with me, so I'll take any questions.
Thank you, Dr. Reinhardt. That's great. I just want to clarify a couple of things actually for us as GOGS. Excellent preliminary data. In a test where you are ruling out a life-threatening event, 85% sensitivity isn't enough. And so ACOG and SMFM have put out a joint statement that this test is not a primetime test. However, that being said, this is actually for GOGS to know. I will actually now be the PI on the Donnie's $3.5 million study. We will be running it out of Georgia and Pennsylvania. And we will be reaching out to sites, so all of you be watching out for emails. And we will actually be looking at this test, because the key to this test is when they did the PRECIS study, they only did it in the inpatient population that was admitted. Key point. It cannot be utilized in the ED setting because it was not done in that setting. And so I just say that because in actuality, an 85% sensitivity even means 15% of people, because what is sensitivity, right? Your denominator in a sensitivity, which is your true positives over your true positives plus your false negatives, is saying if you test positive, what is the likelihood you have disease? But that means you're missing that other half. And so I just want to say, this is the one disease we can't miss 15% of people in, because the ramifications of that is too much. And that's another good teaching point, is when we think about sensitivity, specificity, PPV, and NPV, we can't say excellent or not excellent based on cutoff numbers. It's based on the outcome you're looking at. So if it's an outcome I'm willing to take a 15% risk on, great, there may be outcomes on that. But if it's an outcome I'm not willing to take that risk on, which unfortunately preeclampsia and eclampsia isn't, it still needs to be looked at. So I do think it's a great test, and kudos to you guys for doing that. It's not an easy thing to do. But a key things to this test are, one, it can only really run on a certain platform right now, only one company's platform. It requires space, and so it is going to be studied now at the next level, and it will be done in a, what we're gonna possibly put out as a study where we do what's called a mixed methods entry model, where you actually do a trial where you first don't do the test, then do the test, and see how does provider behavior change, and potentially prolonging time to delivery in the inpatient setting, so not the outpatient triage setting. So just a couple of things about it.
Thanks so much for presenting that data. I'm sorry that you had the wrong set of slides up there.
Me too, it's all right.
That's okay. You did a great job. So a couple of things. When talking to the authors of the PRECIS study, they indicated to me that not all of the patients were actually on the antepartum floor on the service. Several of them were in the OB-ED setting that they consider to be hospitalized. And so that is why, you know, when we looked at it, we did it in that manner as well. None of these patients were considered an outpatient setting. And I think from our personal experience, this test has been an excellent complement to what we consider to be our usual help panel that we like to send. We have gotten test results back that have truly affected what we end up doing to our patients. I wholeheartedly believe in this test. And we actually have the equipment at our hospital system. And for any of you who are interested in drawing that lab and you want to send it to our hospital system, you're more than welcome to, especially if you're not ready to buy the equipment, if you don't believe in the test. I think it's worth trying, because we truly do think it's going to be the next step to help us triage these patients. We have multiple patient stories that we could share with you that we can't share in this setting right now, where it did make or break what we did with a patient that lives multiple hours away, whether we kept them or not. And so I just want people to realize that there's going to be more data coming out and more multi-center data coming out, but great job on your talk. Thank you.
Thank you.
Is it possible to go back to your slides?
Maybe.
Are that horse is out the barn, or? The AUC slide.
Yes, sir. That's a slide that shows that we do an exceptionally poor job of diagnosing preeclampsia with what we have currently.
Okay, stop. Okay. That slide. The x-axis has specificity. Should it be 1 minus specificity?
Yes, sir. Thank you. My real slides were great.
No problem. Thank you, Dr. Reinhardt. And the slide thing can happen to us all. You did a great job, troubleshooting and recovering after that, so we appreciate that. All right, next we have Dr. Melissa Valletti, and from... Oh, I'm sorry. I didn't give you guys a second to vote. Okay, vote. There you go. Take a few seconds. Cue the music. All right, now we're going to move on to our final resident presenter, Dr. Melissa Valletti from Emory, who is going to talk on the effects of cannabis use on the vaginal microbiome. Dr. Valletti.
Good morning, everyone, and thank you so much for the opportunity to present our work. I'm Melissa Valletti. I'm a PGY3 at Emory University, and my research mentor is the fabulous Dr. Marissa Young. Today I'll be presenting on the effects of cannabis use on the vaginal microbiome. I have no disclosures to report. So a little bit of background. Unlike other microbial communities in the body, like the gut or the skin, the vaginal microbiome is a little bit unique in that it has very low diversity, with about 200 known species. Since Ravel et al.'s landmark 2011 study, the vaginal microbiome has been categorized into 5 community state types, or CSTs, as you can see here. Among these, CST 1, 2, and 5 are dominated by lactobacillus species, which are considered optimal due to strong association with favorable reproductive outcomes that have been studied in the past. In contrast, the community state type 4 lacks that lactobacillus dominance and is instead characterized by more anaerobic bacteria, which has been linked to bacterial vaginosis. CST4 has also been consistently associated with poor reproductive outcomes such as preterm birth, as well as HIV acquisition and pelvic inflammatory disease. CST3 is another subtype which is more dominated by lactobacillus iners, and this is kind of seen as a transitional subtype between those favorable ones, 1, 2, and 5, and the shift towards CST4, which is the less favorable subtype. Another way that we characterize the vaginal microenvironment is through different measures of species richness, as you can kind of appreciate in this photo here. It represents the diversity of different bacterial communities. The more favorable subtypes have a low diversity, and the less ones have a higher diversity. Chow and Shannon, for example, are indices that commonly measure this. And we know that a variety of different exposures that patients can experience will influence their vaginal microbiome. This ranges from hosts of factors such as hormonal to behavioral ones, such as tobacco use. Tobacco use has been studied pretty extensively previously. However, one increasingly common exposure that we see in patients, which is cannabis use, remains largely unstudied kind of in this context. So the purpose of our study was to explore the relationship between recent cannabis use and vaginal microbiome composition. We conducted a cross-sectional analysis leveraging baseline data from the CHIME study, a previously published study, which was a longitudinal cohort of HIV-negative patients in Atlanta, Georgia. This study originally aimed to evaluate how progestin contraception initiation affected the vaginal immune and microbiologic environment. At baseline, these patients underwent a detailed interview, a pelvic exam, STI screening, and provided samples of their vaginal microbiome for sequencing. And our microbiome data was generated using 16S RNA gene sequencing, and the community state types, or CSTs, were assigned using a previously validated algorithm. Our exposure of interest was self-reported marijuana use within the 2 weeks prior to their enrollment in the study. And our primary outcome was the CST grouping, as I mentioned previously. And what we did was we kind of categorized these into optimal versus non-optimal CSTs. So optimal, as I mentioned previously, is 1, 2, and 5. That intermediate one is CST3, and the non-optimal is CST4. And so in our baseline assessment, we included 140 participants that both had available microbiome and marijuana use data available. The median age of our cohort was approximately 23 years, and 22% of our participants had reported marijuana use within the past 2 weeks of enrollment. When we examined the community state types, or CSTs, we found no statistically significant differences by age or race. Interestingly, again, unfortunately, while not statistically significant, marijuana users showed a lower prevalence of CST3, which you can see here, and a higher prevalence of CST4, again, that more unfavorable community state type, which are, initial patterns that may merit further exploration. We also looked at the bacterial richness, or the diversity of the bacterial species present, using log-transformed Chow index and alpha diversity via the Shannon index, as I mentioned before. Again, neither metrics showed statistically significant differences between marijuana users and non-users, although visually, if you kind of look at our graphs here, there may be some clinically significant differences that may be worth further exploration. So overall, our initial analysis found no statistically significant difference in the vaginal microbiome composition between marijuana users and non-users. However, these findings are descriptive and very preliminary, and the cross-sectional nature of our data is one limitation that we will discuss, and it limits our ability to study the association more longitudinally. Additionally, we also lacked information on certain key variables such as route of marijuana exposure, thinking about smoking, vaping, ingestion, things like that. However, all that being said, given the limited existing data in non-obstetric populations on this topic and the known associations between marijuana use and adverse obstetric outcomes, we believe that these findings are an important first step. The next phase of our study involves more robust statistical modeling, and we are currently in the works of preparing a manuscript for publication. Thank you so much for your attention, and I am happy to take any questions.
Good job, and maybe this is something we can talk to Marissa about. But my question is, you guys have the preliminary trends that are showing one way.
Mm-hmm.
Even if you don't have method of the intake.
The route.
Right, the route itself. If you could ask number of times per week or something, could you then do a dose response curve? And would that potentially give you a more granular view? And then you might actually get a more statistically significant view, because right now what's happening is you're grouping versus not grouping, right?
Exactly.
And your numbers aren't very high, so
Right.
if you had 10,000 people, there's a higher chance your P might have been, right, like 0.04. But I'm
Exactly.
curious if you could even just say, did you do once a week? Great, block it.
Instead of just a yes, no.
Yeah.
Yeah, the dose response is a really interesting thought. The CHIME study, unfortunately, the questionnaire didn't include it to that level of granularity. But one thing we have thought about looking at is, it asked a lot of exposures to other substances, so that could be something interesting to explore as well. Yeah. Dr. Spin.
Why did you use Wilcoxon instead of paired t-test?
That's a great question. My fabulous mentor, Dr. Marissa Young, MD, PhD, did my data analysis, and I will circle back with her and find out.
Parametric versus non-parametric, that's okay.
Got it, thank you.
There's still quite a bit of stigma associated with marijuana use. So how did you ensure that the patients who said that they were not using marijuana, did you do drug testing, or how do you know that they were not just saying that they didn't because they were concerned about how those results would show up in their chart later on?
Yeah, absolutely. This questionnaire that was administered was separate from any charting documentation, and it was administered to patients they were confirmed that they wanted to enroll in the study, and then they were left alone to fill out the questionnaire, hopefully reducing a little bit of bias, but that's absolutely true. We have no way of confirming. This is all just kind of self-reported data, and an important point of stigma of substance use.
Let's all just consider for a moment, 20% of the respondents
Yeah.
said they smoked marijuana in the past 2 weeks.
Right. 1 in 5.
We need to ask our I mean, so that, but what about smoking as a cofactor, and could you eliminate cigarette smoking? Like, could you tease that out from the marijuana smoker users?
Yeah, so our data did ask about a bunch of different substances in the questionnaire: tobacco, alcohol, marijuana, other illicit drugs. And there's previously data that's been published that shows that tobacco use is linked to the more non-optimal community state types. And so that's why we're trying to parse it out a little bit more with marijuana use, because there's really not published data in non-obstetric patients. And as we know, like the unfavorable community state types are linked to BV, which is very common in our patients. So thank you so much.